Hello everyone, my name is Ziad Ali from St. Francis Hospital and Heart Center. Here at ESC 2023 in the Hotline 4 session, I presented the ILUMIEN-IV optimal PCI randomized control trial. ILUMIEN-IV was the first randomized controls trial that was large-scale, global, and multi-center that randomized patients to OCT guidance or angiography-guided PCI in complex patients and complex lesions. The rationale behind the study was that despite angiography being the most commonly used method to treat patients with coronary artery disease, there are well-recognized limitations. Those limitations can be overcome by intravascular imaging, and we've shown previously that OCT is able to reduce major complications like major dissection and major malapposition and improve the stent expansion. But whether these improved procedural outcomes actually improve clinical outcomes remains to be determined. So we randomized 2,487 patients, 1-to-1 to angiography-guided PCI or OCT-guided PCI, and in the OCT arm, the operators used a specific protocol, first in the pre-PCI to strategize the PCI by looking at the morphology of the lesion length, and the vessel diameter, and post-PCI to strategize and optimize based on the presence of medial dissection, apposition, and expansion. There was two primary powered endpoints of the study. The first was the post-PCI minimal stent area as assessed by OCT, and the second was a clinical endpoint of target vessel failure at 2 years. We also had a safety endpoint of stent thrombosis and procedural complications. The take-home messages and principal findings of ILUMIEN-IV were that OCT-guided PCI did increase the minimal stent area, did increase the stent expansion, reduced OCT-assessed complications, including major dissection, major malapposition, major tissue protrusion, and reference segment untreated disease. We also found that the angiographic complications adjudicated by the core lab were significantly reduced. We did not find a difference in target vessel failure at 2 years. Although we found a consistent 20 to 40% reduction using OCT for mortality and for myocardial infarction, we didn't find that same trend for revascularization, where most of the previous studies have actually shown the largest benefit. Interestingly, when we looked at patients who were enrolled before COVID, the hazard ratio of 0.70 favoring OCT was exactly where we expected it to be. Unfortunately, during COVID, partly due to difficulty in accessing care and partly due to patients really not wanting to seek medical attention or hospitalization, those rates dramatically diminished. And so as a result, the equipoise that we found in target vessel failure was really the result of an equipoise in revascularization rates between the groups. We did find a very meaningful and strong 66% reduction in stent thrombosis, and we found that 96% of patients who had a stent thrombosis actually died or had a heart attack. So overall, OCT does what it says on the box. It's able to identify things that angiography completely misses, and those things that it misses, like the tissue protrusion, the thrombotic complications, the malappositions, and the dissections, biologically are plausible to lead to a stent thrombosis, which was significantly reduced using OCT.